Thank you so much, Dr. Sidra, for conducting this panel discussion. For the next session, session 3, the topic of the session is anesthesia during pregnancy, safe practices in obstetric anesthesia. To conduct this session, I will call upon stage Dr. Sheema Siraj. She is a junior consultant at Patel Hospital.
Thank you so much, Dr. Komal. So, as we are heading towards the discussion on anesthesia during pregnancy, especially focusing on safe practices during obstetric anesthesia, for this session, I would like to invite Professor Noorul Haq. He is the head of the department, Hamdard University, ex-professor and in charge, surgical ICU, director, Abbasi Shaheed Hospital and KMDC, and he is also an examiner of FCPS anesthesia and FCPS pain medicine. We welcome you, sir. And our next chairperson is Dr. Muhammad Hamid. He is Diplomat American Board, Associate Professor, in charge section Cardiothoracic Anesthesia, Aga Khan University, Hospital, Karachi.
I'm calling the first speaker. It is Maida Muzaffar. She is Assistant Professor at NICVD, and she has completed a fellowship training in cardiothoracic anesthesia as well, and working as a cardiac anesthetist. She will be giving talk on anesthesia for non-obstetric surgery during pregnancy. Please welcome Madiha Muzaffar.
Assalamu alaikum everyone. Today I'll be presenting the topic on anesthesia for non-obstetric surgery during pregnancy. Since anesthesia for pregnant patients may not always be only for obstetric reasons, these patients might come at any point during the gestation requiring surgery. Therefore, I would like to discuss the American College of Obstetric and Gynecologists and American Society of Anesthesiologists joint statement on this, their update done in 2019. So how common do we face this situation? The incidence in America and Australia was quite similar, like 0.5 to 2%, but the latest incidence that I found was in an Indian journal of 0.2 to 2%. But in every data, they said in the end that this is probably an underestimate, since there are outpatient females who don't actually know that they're pregnant. So there are probably far more women during their pregnancy in their first trimester that are receiving anesthesia for surgery, and we don't even know that they're pregnant, and we are actually giving them general anesthesia. So, and in another study, in which we saw कि first trimester, second and third, कि जिसके अंदर सबसे ज़्यादा हमारी surgeries होती हैं, it was the first trimester, 42%, then 35% in the second trimester, and 23% in the third. And the procedures that were most commonly done were appendectomy was the most commonest, followed by cholecystectomy, ovarian surgeries, then trauma, and intestinal and breast surgeries. So the chances are that everybody...
Just hold a minute. बेटा आवाज सही नहीं आ रही, इको हो रहा, सही करो इसको. है? ऐसे ही आएगी.
दूर हो जाती है. So chances are that हर कोई अपनी ट्रेनिंग के अंदर एटलीस्ट एक प्रेग्नेंट औरत की नॉन ऑब्स्ट्रेक्टिक सर्जरी ज़रूर कराएगा. Personally मैंने भी 2 ही कराई हैं, एक अपेंडिक्स और एक कोलिसिस्टेक्टमी. So what are the goals that a person should कि आपको एनेस्थीसिया मैनेजमेंट ऐसे पेशेंट्स की क्या करनी होनी चाहिए. तो द गोल हियर इज सिंपली वी आर टेकिंग केयर ऑफ 2 lives, and then the goal would be to provide safe anesthesia for both the mother and the fetus. So it would how we would achieve that is that the anesthesiologist should have a good pharmacological knowledge about the changes that the physiological changes that the pregnant woman has, and that they should maintain the uteroplacental flow throughout the anesthesia that they're providing, and they should know कि अगर कोई drugs use कर रहे हैं, especially in the first trimester, कोई teratogen effect ना हो, and then they should be vigilantly monitoring for signs of contractions of the uterus, and how to prevent it या delivery की तरफ लेकर कर जाना है, तो उसके लिए वो लोग prepared हो. And बेस्ट ये है कि जहाँ हो सके जनरल एनेस्थीसिया को अवॉइड करें, रीजनल की तरफ जाएं. ये हमारे गोल्स थे. अच्छा, अपार्ट फ्रॉम दैट अगर किसी के पास भी कोई केस आता है तो although it might sound scary, but the committee has given a lot of statements which help us in our decision making for such patients. They have actually highlighted some additional points, and they have actually removed certain points as well. So first of all, they have given 3 statements to guide our decision making. ये बहुत broad statements that they have given. Previously जैसे कि कहते थे sedative agents and हमारी inhalational agents जो है उसके ऊपर concerns थे, तो अब उन्होंने इस चीज़ को कहा है कि it is safe, general anesthesia is safe. There are no मतलब teratogen effects. You can अगर आप 3 hours के तक का दे रहे हैं, less than 3 hours का anesthesia, so there would be no neurotoxic effects that they were thinking would happen. So studies आई हैं, there is no evidence to prove it. And other than that, about fetal heart rate monitoring, क्या आपने during the procedure करनी है कि नहीं, उसके बारे में उन्होंने इसके अंदर बताया है. The recommendations that they have given is that first of all, a pregnant woman should never be declined medically necessary surgery. Although it might seem obvious, लेकिन जब भी कोई pregnant lady आती है जिसको जैसे कि अगर distal radial fracture हुआ है और फिर उनको सिर्फ देखा जाता है कि वो pregnant है, तो उनसे कहते हैं अभी splint कर देते हैं, बाद में कर लेंगे. तो लेकिन अगर आप surgeon से पूछें, he would say हम लोग foreign surgery करना चाहेंगे, तो उनको delay कराना सही नहीं है. Any time of gestation अगर उनकी need है, just because of the fetus, they should not be denied. You can do it under peripheral और आपको अपना सिर्फ change करना होता है plan. और having said that, elective surgeries जो हैं, they can be postponed only until after delivery. उसके अलावा आपका ये है about कि patient को corticosteroid कब देना है. अगर आपका discussion होना चाहिए with the neonatologist, obstetrician जो surgery perform कर रहा है, general surgery, उनसे आपका ये close discussion होना चाहिए anesthesiologist से. 24 weeks onwards viable होता है fetus, तो उसके beyond आप steroids दे दें. इन लोगों ने कहा है कि safe है और उससे कोई नुकसान नहीं, ज़्यादा post op nausea vomiting ही नहीं होगा, तो it's better to give steroids especially after 24 weeks. अच्छा, फिर उसके अलावा सबसे आखिर के अंदर उन्होंने कहा है कि these patients are at a high risk of venous thromboembolism risk, so you should always remember that. उनके अंदर फिर ये सर्जरी के बाद और एडिशनल रिस्क आएगा, तो you should give them prophylaxis for anticoagulation. इसके अलावा where should it be done, where these surgeries should be performed. ऐसा इंस्टीट्यूशन हो कि जहाँ पर आपके पास एक न्यूनोटोलॉजिस्ट, पीडियाट्रिक केयर, डिलीवरी के लिए गायनाकोलॉजिस्ट हों. आपको अगर कोई कोलेसिस्टेक्टमी किसी छोटे सेंटर के अंदर सर्जरीज के लिए नहीं लेकर जाना चाहिए प्रेग्नेंट खातून को, क्योंकि देयर आर चांसेस ऑफ डिलीवरी, तो आपको एक क्रेडेंशियल ऑब्स्टेट्रिशियन की ज़रूरत होगी, उसे मौजूद होना चाहिए. और बेहतर यही है कि पेशेंट की जो प्राइमरी जहाँ पर बुकड है उन ऑब्स्टेट्रिशियन से डिस्कस किया जाए. अगर वो नहीं है तो जो भी आपके हॉस्पिटल की ऑब्स्टेट्रिशियन है, शी शुड बी टेकन ऑन बोर्ड इन केस यू हैव टू गो फॉर सिजेरियन डिलीवरी. एंड फीटल हार्ट रेट मॉनिटरिंग की भी आपके पास इक्विपमेंट होनी चाहिए. And pediatric services should be available in your hospital. Fetal monitoring के regarding जो इन लोगों ने इसके अंदर बताया है कि fetal monitoring कब करनी है हमें during या before या after surgery. तो उन्होंने कहा अगर आपका fetus is pre-viable, that is viability जो हमने कहा है कि extra uterine अगर fetus आएगा तो they would survive, that is 24 weeks. अगर उससे पहले का है दैट इज कॉल्ड प्री वायबल फीटस, तो उनके अंदर सिंपली आप सिर्फ डॉपलर से हार्ट रेट बिफोर एंड आफ्टर द प्रोसीजर कर लें, दैट इज इनफ, मोर देन इनफ, और अपना प्रोसीजर कर लें. लेकिन इफ़ योर फीटस इज वायबल, एट अ मिनिमम आपको इलेक्ट्रॉनिक फीटल हार्ट रेट मॉनिटरिंग करनी है and contraction monitoring should also be performed simultaneously. The goal here being to see the fetal heart rate variations आप देख सकें, ताकि आपको पता चले कि इंट्राऑपरेटिवली जो आप कर रहे हैं उसकी वजह से कोई लेबर के अंदर ना जा रही हो. अगर जा रही हैं तो आप सिजेरियन की तरफ मूव करें. लेकिन ये हम इंट्राऑपरेटिवली हर सिनेरियो में नहीं कर सकते. फॉर एग्जांपल आपके पास लेप्रोस्कोपिक सर्जरीज हैं, वहाँ पर आपका कॉन्टैक्ट इतना ही नहीं हो पाएगा कि आप मॉनिटर कर सकें, या प्रोन पोजीशन के अंदर सर्जरीज हो रही हैं तो इट्स नॉट पॉसिबल टू डू सच आपकी मॉनिटरिंग. इंट्राऑपरेटिव इलेक्ट्रॉनिक फीटल मॉनिटरिंग मे बी अप्रोप्रिएट व्हेन ऑल ऑफ द फॉलोइंग अप्लाइड. इन्होंने फिर आगे ये कहा है कि इनके अंदर आप कर सकते हैं इंट्राऑपरेटिव थ्रू आउट आप मॉनिटरिंग, वो तब जब फीटस इज वायबल, फिजिकली पॉसिबल हो ऐसी पोजीशन हो कि आप ले सकें उनका, थ्रू आउट मॉनिटर कर सकें, और आपके पास एक हेल्थ केयर प्रोवाइडर हो जो कि वहाँ पर सिजेरियन के लिए मौजूद हो, क्योंकि अगर ऑब्स्टेट्रिशियन नहीं है तो फ़ायदा क्या है मॉनिटरिंग का। उसके अलावा आपके पास आपकी पेशेंट से कंसेंट हो इफ़ नीडेड दैट यू वुड अलाउ फॉर एमरजेंसी सिजेरियन डिलीवरी। एंड उसके अलावा नेचर ऑफ द प्लान्ड सर्जरी विल अलाउ सेफ इंटरप्शन, आपकी जो सर्जरी है आप इंटरप्ट करके सिजेरियन परफॉर्म कर सकें। जैसे कि अगर कोई माइट्रल वाल्व रिपेयर या रिप्लेसमेंट के लिए गई हुई है, फुल्ली हेपरेनाइज्ड है, यू वुड नॉट गो फॉर सी सेक्शन, तो उसके अंदर इंट्रा मॉनिटरिंग करने की नीड नहीं है। बस आप ये देखें कि आपका सिचुएशन क्या है और उसके हिसाब से आप इंट्रा करें। हैविंग सेड दैट, इंट्रा के अंदर सारे मीट होने चाहिए, लेकिन कुछ सिचुएशंस ऐसी हैं जिसके अंदर आप इंट्रा फीटल मॉनिटरिंग करें, वहाँ पर आपकी मैनेजमेंट ऑफ पोजिशनिंग द लेडी एंड ऑक्सीजनेशन ऑफ द फीटस की आप उसके अंदर मैनेजमेंट चेंजेस आ सकती हैं। जैसे कि आप कहीं परमिसिव हाइपोटेंशन दे रहे हैं, आपने टारगेटेड बीपी कंट्रोल रख रहे हैं, और वहाँ पर अगर आपको मिलता है कि वेरिएबिलिटी कम हो रही है फीटल हार्ट रेट की, तो उसके अंदर आप लेफ्ट यूट्राइन डिस्प्लेसमेंट कर देंगे या आप अपना टारगेट्स को बीपी के चेंज कर लेंगे। तो the decision really depends upon the gestational age of the mother, the type of the surgery and the facilities available, and आपको close communication के अंदर होना चाहिए neonatologist and the obstetrician से। Now the question you should ask when such a case comes to you is, आप पूछेंगे सबसे पहले what is the case, मुझे सर्जरी क्या करनी है, कोली appendectomy क्या है, how urgent it is, what is the patient's gestational age, what has her pregnancy been like thus far, were there any complications, and सबसे important who should attend this call। ये भी ढूंढा था, तो इसके अंदर यही था कि general anesthetist can do it, ऑब्स्टेट्रिक ट्रेंड एनेस्थेटिस्ट का होना ज़रूरी नहीं है जिनके पास फेलोशिप हो, लेकिन ऐसा जनरल एनेस्थेटिस्ट हो जिसने ऑब्स्टेट्रिक की सर्जरीज एटलीस्ट सिजेरियंस कराए हुए हों, तो प्रेफरेबल यही है। और अगर नहीं कराए हुए तो एटलीस्ट उनसे कंसल्ट कर लें पहले। यहाँ पर गाइडलाइंस ख़त्म होती हैं, और थोड़ा सा क्योंकि टाइम है तो आई वुड लाइक टू थोड़े से कार्डियोवैस्कुलर कंसिडरेशंस, जैसे कि हमें पता है हाइपर डायनेमिक स्टेट होती है प्रेगनेंसी की, जिसके अंदर कार्डियक आउटपुट आपको 40% इंक्रीज होता है, SVR लो होता है, वेजो डायलेटेड होता है पेशेंट, BP लो होते हैं, इनके 10 to 20 बेस लाइन से नीचे आ जाते हैं। ये सारी फिजियोलॉजी हमें पता है, लेकिन हमने इसके अंदर ये ऐड करना है कि दीज चेंजेस वुड लीड टू इंक्रीज हाइपोटेंसिव रिस्पॉन्सेज टू बोथ जनरल एंड स्पाइनल एनेस्थीसिया इन दीज पेशेंट्स। आपको ये याद रखना है, नॉर्मल नॉन प्रेग्नेंट लेडी से प्रेग्नेंट लेडी के अंदर ये ज़्यादा हाइपोटेंशन कॉज करेंगे आप अगर एनेस्थीसिया दे रहे हैं। और इसके अलावा ये कि देयर इज़ नो नीड फॉर स्पेशल कार्डियोवैस्कुलर असेसमेंट, एंड जस्ट बिकॉज शी इज़ प्रेग्नेंट, शी इज़ जस्ट ASA2, you don't need to go for any special cardiovascular assessment आपके अंदर, क्योंकि ECG के अंदर जो changes आएंगे that is due to the mechanical changes and the increased blood volume, and if needed echocardiography is safe, but the indication is when you know that the patient has any congenital heart disease, heart valve problem, or a pathological murmur. This is a cardiac disease in pregnancy risk score। अगर कोई cardiac की patient आ रही है जिसका आपको पता है कि valve का या कोई murmur, pulmonary hypertension उनके आगे score दिया हुआ है, वो points आप लेकर incidence of adverse cardiac events भी बता सकते हैं कि आपके during surgery कितने होंगे। रेस्पिरेटरी कंसिडरेशंस आपकी वैसी होनी चाहिए जैसे कि एक नॉर्मल पेशेंट के लिए आप करते हैं, एयरवे असेस करेंगे एंड रेस्पिरेटरी एग्जामिनेशन करेंगे। जस्ट कीप इन माइंड दैट द म्यूकोजल फ्राइबिलिटी एंड एडीमा जो होते हैं फर्स्ट ट्राइमेस्टर से ही स्टार्ट हो जाते हैं प्रेगनेंसी में, एंड दे गेट मोर एंड मोर बाय लेबर के करीब। देयरफॉर नेजल इंट्यूबेशन इज़ नॉट रिकमेंडेड एट ऑल। एंड उसके अलावा आपका द रिस्क ऑफ डिफिकल्ट इंट्यूबेशन एंड प्रेगनेंसी हैंड इन हैंड है, सबको पता है डिफिकल्ट होती है उनकी मास्क वेंटिलेशन एंड इंट्यूबेशन स्पेशली। सो ऑलवेज थिंक इफ़ यू कैन अवॉइड द एयरवे, जितना हो सकता है पेरिफेरल एंड न्यूरोएक्सियल के आप काम करें। एंड इफ़ यू वांट टू गो फॉर एन एयरवे, आपको इंट्यूबेट करना है, ऑलवेज कीप योर डिफिकल्ट एयरवे ट्रॉली विथ यू। उसके अलावा हमें पता है कि इंक्रीज मिनट वेंटिलेशन आपकी इंक्रीज टाइडल वॉल्यूम की वजह से होती है, जिसकी वजह से आपके पेशेंट रेस्पिरेटरी एल्कलोसिस में होती है, pH नियरिंग टू 7.44। देयरफॉर व्हेन यू आर सेटिंग योर टारगेट वैल्यूज़, आपने आप वेंटिलेटरी सेटिंग्स कर रहे हैं तो एंड टाइडल कार्बन डाइऑक्साइड जो आप देख रहे हैं 25 to 30 रखें, थोड़ा लो। और उसके अलावा अगर आपका कोई प्रोलॉन्ग सर्जरी आपने आर्ट लाइन डाली हुई है तो आप ABGs मॉनिटर करें तो आर्टीरियल पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड 30 to 35 रखें। उसके अलावा ये याद रखना इंपॉर्टेंट है कि FRC इनका 20% डिक्रीज़ हो गया होता है एंड दे डू नॉट टॉलरेट एपनिक पीरियड्स गुड, तो इनको आपने प्री ऑक्सीजनेट बहुत अच्छा करना है बिफोर इंडक्शन। ह्यूमेटोलॉजिकल कंसिडरेशंस में जैसे कि उन गाइडलाइंस में भी था कि दीज पेशेंट्स आर वेरी प्रोकोगुलेंट, इनके फैक्टर्स ज़्यादा होते हैं, इनके अंदर थ्रोम्बोएम्बोलिज्म के चांसेस बहुत ज़्यादा हैं, तो आपने अपने दिमाग के अंदर रखना है कि इनको हमने पेरी ऑपरेटिवली प्रोफाइलैक्सिस देनी है जो कि प्रिफर्ड हमारी लो मॉलिक्यूलर वेट हेपरिन है, लेकिन मोस्ट ऑब्स्टेट्रिशियंस जो मैंने पढ़ा है उसके अंदर ये आया था कि रूटीनली स्विच टू अनफ्रैक्शनड हेपरिन व्हेन दे नियर देयर जेस्टेशनल, आपका लेबर के करीब आती हैं 37 के ऊपर, वो उसके ऊपर चली जाती हैं फ्रैक्शन हेपरिन, कॉज बिंग कि उन्हें लगता है कि एमरजेंसी सिजेरियन होगी तो इसके अंदर उसे कन्वर्ट करना, मतलब आपको प्रोटामीन देकर आप ख़त्म कर सकते हैं, फैक्ट हेपरिन का शॉर्ट भी होता है। तो इन चीज़ों को देखें कि किस पर है, अगर नहीं है तो डाल दें अगर टाइम है डिलीवरी के अंदर। उसके अलावा हम although red blood cells increase during pregnancy, but there is more expansion of plasma volume, so there is dilutional anemia. So अगर आपकी पेशेंट का HB 8 से लो है, और या अगर उसको डायग्नोज हुआ है कि उसे आयरन डेफिशिएंसी एनीमिया को आयरन प्रोफाइल के ऊपर 34 वीक्स एंड बियॉन्ड, तो उसके ऊपर इन्होंने कहा है कि आयरन आप रिप्लेस कर कर उसके HB को अच्छा करेंगे। दिस इज़ सेट बाय द नेटवर्क ऑफ एडवांसमेंट ऑफ पेशेंट ब्लड मैनेजमेंट एंड होम्योस्टेसिस एंड थ्रोम्बोसिस वालों की कंसेंसस है। उसके अलावा 6 एंड बिलो, अगर एक पेशेंट she is pregnant and she is non-bleeding, not bleeding at all, तो transfusion is only on 6 and less, वही जो अभी डिस्कशन के अंदर हमने किया था, उसके ऊपर आप ट्रांसफ्यूज़ करेंगे 1 यूनिट, उसके ऊपर आप 7 है 8 है, you don't need to transfuse if she is not bleeding। उसके अलावा GI considerations के अंदर यहाँ पर थोड़ा controversial topic, although NPO has been discussed, कि पेशेंट अगर प्रेग्नेंट है बस लोअर इसोफेजियल आपका जो होता है वो होता है आपका लूज़ होता है आपका, वरना गैस्ट्रिक रेजिडुअल वॉल्यूम लेबर के टाइम पे इंक्रीज होता है। इसके अंदर आपको ये नहीं सोचना चाहिए कि ये फुल स्टमक है तो हम इसको इंट्यूबेट ही करें, हो सके तो आप हल्की सेडेशन के जनरल या रीजनल और पेरिफेरल ब्लॉक्स के अंदर करवा दें तो बेहतर है।
थैंक यू डॉक्टर माइदा, थैंक यू। So now the next presenter is Professor Rafia Tabassum. She's here. So she has a lot of degrees. She has MBBS, she has done DA, FCPS, PGD in bioethics, MCPS in HPE. She's a professor and chairperson, Department of Anesthesia, SICU and Pain Management, People's University, Nawabshah. So she's going to present, her topic is neuroaxial anesthesia in obstetric patient with coagulopathy.
Thank you, sir. Okay, Assalamu alaikum and good afternoon. Today I'm going to talk about using neuroaxial anesthesia in obstetric patients with coagulopathy. This is a very beautiful view of my university. Today I'm going to focus only on 2 learning objectives, and the first will be the anesthetic concerns which are involved in providing neuroaxial anesthesia in patients who are coming with coagulopathy, and we will also learn about the updated guidelines provided by various regulatory authorities regarding this. So I have nothing to disclose. All the materials used in my presentation, it is taken from various websites. So we all know that neuroaxial anesthesia is preferred over general anesthesia because of various advantages which are statistically proved. It provides better pain relief, it provides patient comfort, satisfaction, and reduce opioid side effects. And in addition to that, there is statistically proven that there is decline in the morbidity and mortality in the obstetric patients. Whenever a patient with coagulopathy is encountered with the anesthesiologist, basically the anesthetist come across with certain question, whether to give the neuroaxial anesthesia to the obstetric patient or not, or he has to modify his technique, or to avoid this technique at all. Basically, there are 2 things which should be considered. First, neuroaxial blocks, they are very popular. And second, these patients, the obstetric population, they are exposed to the increased incidence of venous thromboembolism, and they are usually receiving various drugs for the treatment of this. So what to do? First, let's see what is coagulopathy. So coagulopathy, basically it is the derangement of hemostasis that leads to excessive bleeding. So basically the concern of anesthetist is excessive bleeding. When we probe into the causes, the etiology basically is multifactorial. And the etiology is basically concerned with the physiological changes we see in the pregnant patients because there is imbalance between the coagulation and the fibrinolysis. overall majority of the factors, they are going to be increased during pregnancy along with the von Willebrand factor and the plasminogen activator inhibitors. And there is, of course, increased aggregation of the platelets that will cause it a procoagulant state. On the other hand, there is decrease in the fibrinogen, there is increase in the fibrinogen activity, but there is decrease in the fibrinolysis capacity. And that is due to the either deficiency of protein S or increased resistance of protein C in the obstetric population. So, the causes of coagulopathy in obstetric patients, they are divided into three categories. First, they are maybe due to thrombocytopenia, or it could be because of the inherited disorders or the acquired ones. Let's see what are the platelet disorders we commonly encounter in the obstetric population. Basically, they may be thrombocytopenia because of the immune in origin, or it could be gestational thrombocytopenia because of the volume expansion or due to the hormonal effects. The most dangerous is the thrombotic thrombocytopenia, that is in which there is microangiopathic hemolytic anemia, severe thrombocytopenia. These patients may present with the platelet count less than 30,000 per cubic mm. And then we commonly encountered in our practice with the preeclampsia and the HELP syndrome, a main hallmark of which is low platelet counts. DIC, that can be because of the amniotic fluid embolism, sepsis, or intrauterine fetal demise that can lead to increased consumption of the platelets. Hemolytic uremic syndrome is another cause that can cause platelet disorders. When we see what are the inherited factors, so basically there are either isolated deficiencies or there are other factors, including von Willebrand factor disease or hemophilia, A, B, or C. The first one is basically an autosomal dominant disease, and the second one is the X-linked disorder. Basically, in hemophilia, the women, they are carrier of the disease. But still, if one of the X chromosome, it is defective or disease, then it can cause this spontaneous hemorrhage in these obstetric population. Because of the increased incidence of VTE in obstetric population, there is, of course, rise in the use of the anticoagulants, antithrombotics, and antiplatelets. And these drugs, they are really producing very different and problematic effects. And other causes seen during the pregnancy, they are acute fatty liver changes, and maybe malignancy could be there, or sepsis is again another factor. So how we can manage? If there is thrombocytopenia, depend upon the type. In the gestational, there is no need of any intervention. In immune type, they say that give corticosteroids, or in addition to that, you can give desmopressin. While in thrombotic thrombocytopenia, use plasma exchange before undergoing elective surgeries. And you know what is the treatment of preeclampsia or HELP syndrome. In the DIC, the underlying cause should be treated. Whenever we talk about the inherited disorders, basically they need replacement of the factors in which are deficient. They may be, we can give concentrates of those factors, or even we can administer, if we don't have those costly factor concentrates, we can give cryoprecipitates or fresh frozen plasma. What about the anticoagulants and other drugs which are being used? So we will discuss these drugs in the upcoming slides, how to deal with, because there are certain guidelines which are present. So far we have seen that either the coagulopathy is because of thrombocytopenia, it could be because of the isolated factor deficiencies, or it could be because of the different drugs. Let's see what various regulatory bodies they say. If we see that the Society of Obstetric, Anesthesia and Perinatology, which is most commonly known as SOP, they given their practice guidelines first time in 2007, and then they are updated and published in 2015. And they say that it is left on the discretion of the anesthesiologist whether to advise for the routine platelet count or not. It depends upon patient's history, physical examination, and also the clinical findings. So in a normal, healthy parturient, there is no need to go for the platelet counts, because yet no specific platelet count that can cause neurological complications or other complication in the obstetric population determined. If we look into the American Society of Anesthesiology statement, they have actually talked about various complications which are relevant to neuroaxial anesthesia. When they talk about the neuroaxial hematoma, whether spinal or epidural, they say that the incidence is very low. It is 1 in 200,000 or 1 in 250,000. That is extremely rare. Because if we compare it with the patient who are undergoing the orthopedic surgeries, the risk of this hematoma is much more higher. That is 1 in 3,600. And in addition to that, they also identified that even this hematoma occurs in the absence of the neuroaxial block. But once it happens, it needs to be identified immediately so the patient can be rushed for the evacuation of the hematoma. Otherwise, it can cause permanent neurological problems. So every patient who is undergoing neuroaxial anesthesia needs to be monitored for the first 24 hours for the red flags. And these red flags are lower back pain, fever, or motor or sensory deficits, or even urinary bladder dysfunctions. If we talk about how we can diagnose, so MRI is the basically gold standard. And in this picture, you can see that there is presence of the epidural hematoma in thoracic as well as lumbar regions. Then there are certain studies which are conducted to see whether which kind of the patients who are suffering from inherited or acquired disorders, they are mostly suffer from these complications. In the first study, that is a cohort retrospective studies, they observed that the patients who are suffering from inherited disorders, they were very common among the population, but still the adverse effects, they were very low. And in another study which was conducted, in which the patient who are coming for the spinal anesthesia with coagulopathy or without coagulopathy, they were compared. And they see that the incidence of these complications was only 0.2% in the patient who are coming without coagulopathy and 0.23% in the patient who are coming with coagulopathy. Then, what could be the safe levels of the platelets? Then again, the SOAP guidelines, they come into the ground and they say that if the level of the platelet is greater than 70,000, then the anesthesiologist can proceed with the neuroaxial block. But if the level is between 50 to 70,000 and there is some contraindication for the placement of the neuroaxial anesthesia, then it is better to be evaluated further. If the level is less than 50,000, then it should be avoided. And if the patient is coming in the labor or delivery suite with new onset of thrombocytopenia, then it needs to be worked out more. These two guidelines, which are provided by the ISRA and the SOAP guidelines, in which the patient were receiving thromboprophylaxis or anticoagulants, so they say that you should consider three things. Number one, what is the indication of the use of these medicines? Whether they are given for the therapeutic or for the prophylaxis. Number two, what is the dose of these medicines? They are giving in low dose or high dose. Number three, what is the time interval that is elapsed between the last dose and placement of a neuroaxial, or the last dose and the removal of the catheter if it is in situ? So these three considerations, they are very important and they need to be addressed before placing the neuroaxial anesthesia. What's new? If we are going to inculcate all these guidelines, we come to know that whether ASA, whether SOAP guidelines, they all stress that routine platelet count is not necessary to see, and until and unless severe thrombocytopenia is present or it is evident in the labs, it is not necessary that neuroaxial anesthesia should be not be used in these patients. And here comes the point of care coagulation test that can be done. This includes thrombolastography and the ROTAM, that is rotational thromboelastometry, or another latest technology that uses ultrasound, that is the Quantra-R. Let's have a scooping review of all the studies, all the articles I just shown you. All these studies, they have gaps. And there are significant gaps between these studies. They are either related with the population, with the data, with the evidence, or with the medicine. Most of them, they were either retrospective studies, or they were narrative views, or they were basically the case series or studies. Systemic reviews, they were absent. Type of anesthesia used, or what about the drugs patients were taking, again, it was missing from most of the studies. So there is the need of conducting more and more research to support the evidence, because the main goal of this is to improve the patient maternal and fetal outcome. And in addition to that, it is very essential that any patient who is coming for the obstetric anesthesia with coagulopathy needs to be monitored with a multidisciplinary team that involves an anesthetist, obstetrician, and in addition to that, a hematologist must be present. And that will lead to improved feto-maternal outcomes. And we can see and we can take the help of the various guidelines. But still, systemic review research is needed in this field so that proper and evidence-based guideline can be formulated and used. Thank you very much.
Thank you, Dr. Rafia. So the next speaker is Dr. Faisal Khan. He is going to present updates of maternal cardiopulmonary resuscitation. Dr. Faisal Khan is Assistant Professor and Consultant Department of Anesthesiology and Section Head Critical Care, and also his Chair Resuscitation Committee, Aga Khan University.
Thank you, Dr. Hamid. Thank you, PSF, for inviting me. It's really a pleasure to be here. So before starting, I just would like to know how many of you have come across or managed or been a part of the team who the patient has happened the maternal cardiac arrest. So there's only one hand is raised. So I would just brief you about the updates on the maternal cardiac pulmonary resuscitation. So just the first slide that I have nothing to disclose here, except I would like to start my talk with the case presentation or the case summary. This case has happened last year at AQ. It's been published by one of my colleagues in a journal. This was a 35-year-old female, gravida 1, para 0 at 28 weeks of pregnancy without any comorbidities. And she conceived after 9 years of marriage. She became pregnant and was managed in a district hospital. She presented to the ER with the preterm premature rupture of the membrane. She was first admitted to the labor room where she showed some sign of hemodynamic instability. And then she suffered a cardiac arrest after the admission. And during a CPR, a resuscitative C-section was performed, later hysterectomy. And later on, she was diagnosed with a case of severe mitral stenosis. And she had a hysterectomy done in the hospital. She stayed in the hospital for a month and later discharged with no neurological deficit, but she had tracheostomy. In last year, because I chaired the committee, so in last year we had 2 incidences happen, one in the ED and one in the labor room, as this case is mentioned, and both, alhamdulillah, had a very good outcome. So these cases are rare, but of course this requires a lot of team skills and the team dynamics in managing these cases. So here, my talk would focus on some epidemiology and the approach to managing the pregnant patient who has been on cardiac arrest, the differences in the management, and the rationale of the peri-mortem cardiac arrest. So the context is important in terms of the maternal cardiac arrest, and because it has a unique challenge and it's a unique complexity, because more mother and fetus are considered as a patient. And in this type of management, usually the resuscitative interventions are concurrent rather than sequential. and the treatment algorithms are modified based on pregnancy and gestational age. An early consideration of cesarean delivery is an important step to optimizing the outcome. So before going to the management plan or discussion, I would just like to focus on some epidemiology. And unfortunately, we don't have a nationwide data, but here I just would like to put through the some data in the western part of the world. This is the Canadian nationwide registry, which highlighted the problem list, what are those associated factors or those maternal comorbidities that can lead to the problem. And of course, the moderately adherent placenta, placental abruption, and polyhydramnios on top of the list in terms of the obstetric causes. And in non-obstetric causes, the hypertensive disorders of pregnancy. But lastly, in non-obstetric, the non-pregnant, the malignancy in top of the list in their registry, they have some incidence of cardiac, the maternal cardiac arrest. And in total, the incidence is around 1 into 2,500, but the survival rate is pretty good in terms of, it's around 71%. And when they try to find it out, the other, the typical associated factors, the amniotic fluid embolism and the heart failure was on top of the line. And if you see the American data usually present the same type of medical illness. In their data, the postpartum hemorrhage and the antepartum hemorrhage, as well as the peripheral cardiovascular disorders are on top of the list that can lead to the problem of cardiac arrest in maternal group of patients. And their survival rate is also mentioned, and it's around 59% in their data. So if we move from the Western world or the developed part of the world to the developing countries, this is the Taiwanese data I could found, and they had seen their 10 years data of maternal cardiac arrest and deliveries. And, in their registry, the incidence is around 1 to 3,000 or nearly more 4,000. And also, they have the same type of cohort like cardiovascular disease and hypertensive emergencies on top of the list that can lead to that problem. But if you see the maternal outcomes, so the maternal death is around 87%. So there's a big shift. The problem list remains same, but the outcome data is really challenging. And the neonatal death was around 26%. 26%, yeah. And of course, we also wanted to know about what about the fetal outcome. So this is the UK prospective study. They prospectively seen the 66 cases of maternal cardiac arrest, and they found if the perimortem cesarean delivery has happened within time, and the target time is around 5 minutes, there's a 96% chances of the survival for the fetus. And if it is delayed for more than 5 minutes, there's a 70% chances of the good fetal outcome. And if you see all these registries and we try to find out the trends of what is happening in terms of these type of complications, so the trends looks like that is increasing. And this is again the US data, which was published in 2012, more than 10 years back. And you can see the trends of acute renal failure and cardiac arrest on second line, that the trends are increasing. I'm not sure about that. This is because of the disease pattern, or this is because it's now more reporting is being happened rather than this is under-reported. So this could be because there are more registries, more data is coming out, so might be the trend is increasing, but I don't have a very true answer on this. And we all know now, from the epidemiology to this pregnant cohort, we all know that there are some challenges. And the challenges in terms of the cardiovascular, the respiratory, and the anatomical changes. And we all, you people have a better idea rather than me that what type of cardiovascular challenges they may have. They have low FRC in the respiratory, high metabolic demand, low SVR, high cardiac output. And all these these physiological changes can lead to some problem, and they can make this group of people more propensity to develop the cardiac arrest. But what about, are these pattern is preventable, is this disease is preventable. So there is 60% chances that we can prevent this. And how we can prevent this? Of course, it is important to identify the high risk group and how this can be highlighted. Either this is the early pregnancy or the late pregnancy. So if we can identify the risk of cardiac complications, proper history and physical exam, personal and family history data, and history of smoking, hypertension, diabetes, family history. So these are those risk factors that this can alarm us to have the problem in future. And of course, in the late pregnancy, some people have cardiomyopathy, postpartum hemorrhage, preeclampsia, and severe features of the preeclampsia. Then these are the group of people that they can come across with these unfortunate events. So now coming to the cardiac arrest treatment algorithm and what is the literature and what the guideline says about it. So there is slight changes. As we all understand, this group of people is different. So these are the summary of the changes. And of course, whenever we have seen it, whenever there is a code blue happen in any ward, usually the code blue team arrives, and the code blue team have some group of people. But in the maternal cardiac arrest, this is not a typical code blue team. You need few other members, and those members are the obstetric team, obstetric doctors, and the obstetric nurse, and of course the neonatologist, because we also see the outcome of the fetus. And why you require this, because you want the perimortem or the early cesarean sections. The maternal maneuvers is also important, like the chest compression above the center of the mid of the sternum, left lateral uterine displacement, which is another important activity during the resuscitation time period. And of course, they also wanted to teach us that you don't need to monitor the fetal monitoring or the CTG whenever the event has happened. So these are some maternal maneuvers. These are really needed when the maternal cardiac arrest happen. And of course, as an anesthesiologist, we are much interested in the airway. So the senior anesthesiologist is required. And in terms of the other cardiac arrest in other groups, and the pregnant patient, it is advisable to early intervene in the airway as compared to the after passing 2-minute cycle or a 4-minute cycle. And of course, they use a small size ET2 tube, which is also important because of the anatomic consideration. This is the last updated guidelines of the AHA, which was just recently published in 3 years back. The first guidelines came in 2015. Most of the things are similar as compared to the other cardiac events in other group of patients, but they highlighted that, of course, the maternal cardiac arrest team is required, which is necessary, and they divided the portions into two. They perform the maternal interventions and the obstetric interventions, high quality CPR, early airway intervention, oxygen. The IV line should be placed above the diaphragm. This is one of the focus area. And most of the time, the pregnant patients are on magnesium, so they highlighted that you should consider the calcium gluconate or calcium chloride in terms of the management. And performing the obstetric interventions, of course, as mentioned earlier, the lateral uterine displacement, detach the fetal monitors, and prepare for perimortem C-sections. And of course, you need to continue all other things like the high quality CPR and other stuff. And whenever we all know, we have been involved in the cardiac arrest situations in the OR and outside the OR, we also talk about the HNTs, and this is the big list of HNTs. You all know better than me, I believe. So I'm not going into the details of it, but this is the list that we all need to consider. To keep the thing more simple, the UK guideline, usually they give you the mnemonic from A to H, and they highlighted the anesthetic causes is number 1. And of course, it has some reason. The reason behind is this: in their data, the anesthetic causes, 1 into 4 cardiac arrests usually happen because of the anesthetic. So there they highlighted that it should be the number 1 rather than it's coming as an A. And of course, the bleeding, cardiovascular, the drug-related embolic fever, hypertension are the other part of the HNTs that need to be considered whenever we deal these type of patients. I'm just going into the some few details about the cardiac arrest algorithm, like circulation, airway, breathing, defibrillate, and expected the extraction of the fetus. This is just a diagram of what we need to do during the circulation part. One member of the team would do the chest compression. The other member can help in the uterine displacement. So there are 2 methods they have mentioned. Either whenever the person is standing, either the right side or the left side. If you are standing on the left side, of course, you need to make a 2-hand method. If you are standing on the right side, you can use it by single hand. And this usually this phenomena helps in the relief of the aortocaval compression. The chest compression rate remains similar. Regarding the defibrillation, of course, it's important. There is no need to reduce or increase the joule size. So these requirements remain same. Again, the removal of fetal monitoring is desirable because it distracts the person who is involved in the cardiac resuscitation. The AHA guideline, usually the AHA data tells us about in terms of the shockable versus non-shockable. So they mentioned that 76% is usually the non-shockable rhythm. And if I just give you our examples, so in both of these 2 cases that has happened, both are were having a non-shockable rhythm. Few lines or few slides about the perimortem cesarean delivery. Cesarean delivery is recommended if the ROS not achieved within 4 minutes of maternal cardiovascular collapse, and the goal is to deliver within 5 minutes, more than 20 weeks of gestation. If appropriate, you can do the instrumental vaginal delivery as well. It all depends on the expertise of the team. The rationale of the perimortem cesarean delivery, because the irreversible brain damage can occur in non-pregnant patient after 4 to 6 minutes, so pregnant woman has more high chances of getting it. So I'm just giving you few lines about the modified Delphi approach is being used by the OBLS, the Obstetric Life Support Group, and they just highlighted because if you see the cardiac arrest data, they talk about the ECMO and the point of care ultrasounds. So the Delphi, the AHA does not recommend, it does not provide any details so far, but the Delphi approach, the OBLS 2022, they published, and they thought that ECMO, this is the time that ECMO can be included, and the point of care ultrasound need to be included in maternal cardiac arrest as well. So they talk about the point of care ultrasound is important to identify the gestational age, to identify the remnant of the placenta, and of course it also helps in identifying the causes of cardiac arrest. ECPR, this is included in the AHA in the non-pregnant or the normal cohort, but of course it's included as per the OBLS 2022 that it can be the part of it, and it increases the survival of around more than 80% if it is required under the ECMO centers or with the expertise hands. This is one of the accreditation requirement. The Joint Commission USA, the Joint Commission International also advised that there should be a separate team for dealing with the maternal cardiac arrest situations rather than rely on the same team who deals all the patients in different areas. And of course, there should be a local protocols to identify the issues and to come up and overcome all these issues. So the summary is that, of course, to maximize the outcome of maternal cardiac arrest, a modified and multidisciplinary approach is necessary. Knowledge of the key differences of cardiac arrest in pregnancy is important. Multidisciplinary simulation team should focus on both technical and teamwork skill in order to be the most effective outcome. And as mentioned, our health minister as well in the morning talk, we should have our own registry data so that we can identify our own risk and we can modify our own guidelines. Thank you so much for listening.
Professor, please stay, Dr. Faisal.
I would like to thank all the wonderful people who spoke with such an amazing lineup. I would also like to express my sincere gratitude to all of you for sacrificing your precious time and opted to attend this valuable conference. In the end, I would like to welcome Dr. Hamid and Professor Noorul Haq to present the certificates to our presenter. Now, starting with Dr. Maida Muzaffar. Professor Rafia Tabassum. Sir, आप बैठ जाओ.
Question answer session आपने miss किया.
Dr. Maida Muzaffar. Dr. Faisal Khan. Okay, so if you have any questions, our presenters are here and you can ask any question regarding this session.
I think all the lectures were self-explanatory.
Dr. Amin Khwaja.
Amin Khwaja.
Mike.
My question is, Dr. Rafia, you have presented guidelines and your talk was very updated. What the practically in our institute, what we are doing, if the platelet count is less than our 80 and patient is taking an anticoagulant, all the coagulants, so what to do in our setups? Because they've got a lot of studies and things, but in practically, what is the take-home message for the youngsters? What to do in our situation?
Thank you, sir, for asking the question. In our setup, basically, whenever the obstetric patients get admitted in the delivery suite or the labor room, the first investigation usually sent by the obstetrician is blood CP. Because in our setup, they are most concerned with the anemia rather than the thrombocytopenia. And if all of a sudden or accidentally or incidentally it is found out as a significant reduction in the platelet count, then usually they proceed with the arrangement of either the whole blood or they will ask for the platelet concentrates. At even Nawabshah, you are asking about our setup. Our setup, Nawabshah is a remote place.
I was just concerned about...
In our setup, platelets, they are available. If the patient is suffering from thrombocytopenia, whatever, if there is defective coagulation factors, then there is availability of the FFP, I think, everywhere in Pakistan. So it's not difficult to counteract these problems.
So you will suggest that those patients should have a neuroaxial blocks for... They should proceed with the blocks for the...
Depending upon the conditions and the scenario. In one of my slides, I emphasizes that these patients should be dealt by the multidisciplinary team, and in addition to that, an expert anesthesiologist should deal with them. Because if a junior or a resident dealing with these obstetrical patients, even the count, if the count is 70,000, then still there are chances of putting multiple attempts, and that can lead to basically hematoma. But again, the incidence is so low that that is almost negligible.
I have a question from Dr. Faisal. You give a very good presentation. How many operating rooms or hospitals do you know where they can get ready in 5 minutes to do a cesarean section from the labor room or from the ward to the OR? 5 minutes.
So if I correctly understood your question, you're asking about how many times in how much time?
How many of our hospitals are equipped to do a cesarean section within 5 minutes?
So I think this is very, very important. So let me, I don't know about the other hospital, but let me give you the example of my hospital. Because I chair the committee, and we did one mock code on the maternal cardiac arrest in a routine ward, not in the and we try to develop a system that whenever the event happens, then usually it takes 3 to 5 minutes the team would arrive. But in the maternal cardiac arrest, we had a challenge, because as Dr. Rabia mentioned, when the incidences are low, so the problem usually, the result would not be good because the people are not trained, they have low reflexes. So in my particular case, of course, the other team has arrived because they are used to, their reflexes are very much strong when the code blue pager beeps. But the maternal team arrived a bit late because they are not used to. They have listened in the one is in a year. So they took 6 minutes, 6 or 7 minutes, because they were struggling that where we need to go. But the whole process took around 12 minutes. So it's done. But they have started the process in total in the 7 minutes. And you can see this in the UK data as well, because they very, publish their issues as well. They highlight the problem. And they have also, usually they have an average time is around 10 minutes. So the challenges would be there, but I think the key focus here is that the people should know. They need to know how to respond, how to early respond, and what thing they need to do as much as possible. I think this is one of the key yeah. But I'm not sure about the other hospital, but yeah. And that's why I mentioned that, we should have some sort of data, maternal, so that it may sensitize the people more.
All right, thank you. Any other question? I don't think anybody has any. Just one question to Dr. Faisal. So if you are doing a defibrillation in a pregnant patient with a fetus inside, so what would be the effect of the fetus? What would be the effect on the fetus if you are using a defibrillator? Or it should be done after delivering the baby?
No. So suppose if the patient has a VFib, so you can deliver the shock, okay? The only thing is recommended as per the guideline that only you need to remove the fetal monitoring because it has some risk of electrocution. And whatever the requirement is, they need to be given as a routine dose, whatever is required in non-pregnant and the normal cohort. So if the patient requires 200 joule in VFib, the patient should be given a 200 joule. And of course, if you are not successful in less than 4 to 5 minutes, you can go proceed with the perimortem cesarean.
My question is, what would be the effect on the fetus?
So the fetal outcome,
probably he will develop defibrillation.
I mentioned
he
about
will
the
need
fetal
defibrillation
outcome.
Afterwards.
the data I try to present here, the fetal outcome is not bad in terms of proper maternal cardiac resuscitation. The fetal outcome rather it's good if the process is being completed within a time with a good quality process.
So, any more questions? So, now we would like to conclude our session. I would like to invite Professor Saleh Khashkeri to present certificates to our chairpersons. Dr. Muhammad Hamid. Professor Noorul Haq. And to myself.
Thank you so much, Dr. Shima, for conducting this session. I hope you all are following the QR scanner. The QR code is being displayed on the screens. Please scan it for your e-certificates. The QR code for the session 2 is being displayed right now.